Hi everyone, my name is Julian Clemente and I will be presenting my capstone project today, and it's about seeking change in the hospice process. I chose this project because of my previous work experience. I used to work in the hospice setting for a little over than a year, and this project is something close to my heart. It's based on my experience, on my assessment on what is wrong in the hospice population, which is, I think, one of the most vulnerable population in our community at the moment. I've worked for a hospice agency in the valley previously, and I worked with home-based hospice patients. What I see in the hospice population right now is the lack of autonomy regarding their decision with care. And often we go to the families instead of going to the patient directly for decision making. Families' opinions are being valued more than the patient's at end of life. What I see in this problem is that even though the patients are still able to make a decision for themselves, we go to the families first if they agree to what we're gonna do or not. So the patients often lack that dignity that they need at their end of life. There are two areas in hospice care: inpatient and home-based hospice. And there is usually an interdisciplinary group that cares for the patient, which is composed by the medical director, the RN case manager, the CNAs, social workers, and spiritual counselors. When it comes to the patient, is no longer able to communicate what they need, there's usually a dilemma that comes with it, especially with the family not knowing what to do or what to expect. So they often try to hide stuff from the patient, the fact that they're transitioning to end of life, which the patient deserves to know because they know their bodies, they know what's coming. As the patient transitions, many symptoms usually show, such as labored breathing, terminal agitation, and pain. These symptoms cause the family to panic, and even cause some to think that they are making the wrong decision by not seeking a further aggressive treatment for their family members, which causes revocation to hospice care and going back to seeking aggressive treatment. As I've done my research regarding this issue, I have seen that there's very limited research conducted to patients in the hospice population, and it's usually research regarding family members on how they cope, but there's very limited research regarding the patients' say on things. So what I've seen that we need to do is encourage research on this setting, especially to patients who are still able to communicate, and even they just been signed up on hospice care, so they're still able to communicate effectively to the providers. Hospice and palliative care nurses have a specific role in caring for the patient, which is far from nurses in other specialties because it involves a lot of emotional support and lots of teaching regarding the death and dying process, and being able to have the patient and family accept what is about to come so that the experience can be a little easier for everyone. My my question that I examined during this process is that in the hospice population, does having a preference of treatment initially signed by patient during admission compared to not having one signed affect the increase in patient autonomy and quality of life within the first month of hospice admission. We don't usually have like a signed contract on what the patient wants regarding the treatment of care, especially with regarding pain management. And usually, when that time comes, there is a dilemma because families have to decide if the patient is not able to communicate anymore. So this gives lack of autonomy to patients, and and we don't know how the patient will want that to happen. I have encountered when patients reach the end of life, a lot of family members either refuse to have any narcotics administered, but research suggests that in this process, patients usually experience intolerable pain. So, as nurses, we have there's no contract on what the patient wants, we have to follow their families, even though we already educated them and explained to them that pain management is necessary at that point. My nursing diagnosis to this population is knowledge deficit, especially with patients and family, because they haven't been through this process, so they don't know what to expect. Lack of knowledge and education provided to patients and families can cause decline in patient satisfaction, and education regarding disease process and symptoms management can increase the nurse to patient engagement. And another diagnosis is risk for ineffective coping. As a patient with terminal diagnosis, difficulty coping is almost always a part of the problem, since patients and families can be anywhere in the part of the grieving process. My plan for community education to this project is to increase the number of research work in the hospice setting by the hospice nurses to increase evidence-based practice regarding this issue. Also, goal is to increase satisfaction with care by increasing patient autonomy. The plan for community education again, the cultural considerations in the setting is to improve communication on patients who have their own beliefs regarding death and dying and respect their ways on how they want to pass. Evaluation method we will use is the questionnaires to be handed out to patients and compare the response of the questionnaire handed before and after the implementation of change if the patient satisfaction increases. Interventions that we are going to use is to improve the data collection and storage with a hospice care, since there's a limited data regarding this issue. Also, to increase evidence-based practice in hospice nursing, provide supportive psychotherapy to patients, increase in patient autonomy, and very importantly is teaching and education to nurses regarding improvement in hospice care. I have shown a graph that showed the problem, the milestones, and the approach that we need to take to resolve this issue. Um, and for evaluation, I recommend that a survey should be conducted in both inpatient and outpatient hospice setting, asking the same question, from 0 being the least and 10 being the best. How autonomous do you feel in controlling your life decisions and decisions regarding your treatment options? And the result will be compared. My research reveals that there are limited studies regarding the autonomy opinions of hospice patients, and that there are limited data overall regarding the thoughts and values of this population. Ethical variable sway in this issue since many researchers feel uncomfortable gathering data and making dying patients a subject of their study in their final days of their lives. And clinicians often feel like dying patients have more issues they need to address instead of spending time answering questions to gather data. I have encountered a few occasions that families do not even want to mention word hospice to their loved ones and will avoid discussion of dying to the patients themselves. And this can very much hinder in the care and quality of life that the patient is entitled to have in the final days of their life. Death and dying is a part of life and should be addressed as valuable as giving birth. Looking back into the beginning of our study in nursing, there is a whole curriculum regarding maternity and newborn nursing, but there is not even one chapter regarding hospice care. I communicated my research findings to my coworkers, and they had agreed that there is a lack of study in this population, and we should value the patient's statement more in this setting than the family members' opinions. That concludes my presentation, and I would like to thank everyone for listening. And if there's no further questions, then this concludes my presentation.